So my name is Min Liu. I'm part of the Washington Sports Medicine Institute. I also work for Ortho Bethesda. So this practice location, as well as Bethesda, Maryland. I grew up in New York, graduate of the University of Chicago, and I did my fellowship training in hip and knee replacement in San Francisco. Spare time, I enjoy hiking, skiing, and cooking. We moved back to Maryland for my wife's family. We have 2 kids, and our in-laws help us a great deal with the kids. They're young, they're 1 and 3. So how did I get into orthopedics? Growing up, I was always very interested in sports. I was very active. I rode, I ran marathons, played a lot of basketball in my lifetime. And so when I got into medicine, the thought was always to help people keep moving because that meant a lot to me. And orthopedics was a natural confluence of my interests outside of work with the science of medicine. Then as I progressed through orthopedic training, the more I learned, joint replacement really became a focus because of the degree of impact it had on people's lives, how much of an improvement of quality of life people had. And it was really fulfilling to watch those surgeries and eventually learn how to do them. All right, so before we get into all of that, I'm sorry, my practice locations, once again, okay, I apologize. Okay.
It's like really like iceberg.
Okay.
Like ice skating deeper after.
Is this camera doing anything? Okay, I'm gonna move a little closer too. Yeah. Okay, I'm gonna move closer, move up. Yeah, this camera is not part of this. I'll speak up. All right, so I practice over here, which is the Tyson's Corner location, as well as in Bethesda at the Camilleri building, which is on Fernwood Road. I do surgery at Suburban Hospital, as well as various surgery centers around the DMV area. Okay, so we have various locations for everyone to come and see us. But this is one of them. Thanks for coming here. This is a relatively new location that's been up and running over the last year. So orthopedic surgery and joint replacement are constantly evolving. The field has undergone tremendous change. And so I basically gave this exact talk about 10 years ago, but a lot of this has changed. And so this is one of the reasons to do this thing is, you know, it really lets you reflect and kind of appreciate all the improvements that we're making in the field of orthopedic medicine. So I strive to treat patients with accordance with the most modern and up-to-date principles. And I really treat patient care as a great privilege and a lifelong journey. All right, so a brief overview of the talk. So we're going to go through some of the non-operative treatments that can be done for hip and knee arthritis. We'll talk about developments as far as outpatient surgery, as well as newer methods of anesthesia and pain control. We're going to talk about anterior hip replacement surgery, the improved biomaterials that are now used that allow for us to expect longer lasting joints, and then also robotic assisted surgery, if that's something you're interested in. I understand that not all parts of this talk will apply to everyone, but I'm gonna try to cover everything comprehensively. So non-operative treatments. Let's start with what is arthritis. So arthritis is wear and tear of the cartilage surface at the joint articulation. It can happen at any joint, can happen in your shoulder, in your hand, in your hips and knees. It tends to happen to the lower extremity weight-bearing joints because, you know, not surprised, you can't rest those joints effectively like you do with upper extremity joints. So whereas you could rest your hand or your wrist or your elbow when those get tired or damaged, with a hip or a knee, you can't, you know, exactly be off of those for a very long time. So that's why lower extremity arthritis tends to be very prevalent, very common. So the more damage there is, it eventually leads to inflammation, swelling, and pain, and then, ambulatory dysfunction, difficulty with walking and with daily activities. So that's a nutshell with what arthritis is. So what can we do about this? So treatment options go from, the most conservative, simple things to the most aggressive, which includes surgery. So the simple things, like I just alluded to, rest, activity modification, avoiding stairs, avoiding higher impact things like running, jumping. Anti-inflammatory medication like Advil, Aleve. So those would be the most straightforward, basic treatment options. Then you go into weight loss, muscle strengthening, and physical therapy. Those are also some of the more conservative measures that you can try. The next step up from that is bracing, applying a knee brace, for example. That can be done judiciously. You shouldn't wear a brace all the time, because if you do that too much, then the muscles will atrophy and the condition will get worse. And so we advise judicious bracing, such as, for example, if you go out and go on a long hike, or you're wearing your brace when you're working your yard, but not all the time every day. The next step up from that would be something like injections. So corticosteroid or steroid shots, that's something that's commonly done for arthritis. That's basically like putting Advil or Aleve straight into the knee joint or hip joint, and that's to quell the inflammation. It doesn't get rid of the arthritis, it just controls the inflammation and pain. And who knows how long it will last. It's expected to last 2 or 3 months, but it could last longer. Inflammation is like a switch. So you turn it off and it may not come back for a while. Another alternative, which you may have heard of, is these gel shots or hyaluronic acid, HA, like Synvisc, Supartz, Euflexa. There's different brand names. They're advertised all over the place. The gel shots are an alternative to cortisone. They're not necessarily better or worse. It's just a different type of medication to put in there. And we consider that if the cortisone does not work. And lastly, so if all conservative treatments have been exhausted, then there's surgery, which consists of joint preserving surgery, meaning arthroscopic surgery, or joint replacement surgery, which is arthroplasty. People ask, can you just shave out the arthritis and, take care of that way? Not as simple as that. If you shave out the arthritis, then the lack of cartilage and the joint damage will still be there. So you need to restore the normal mechanics, and that's where joint replacement comes in. So what kind of differentiates between a joint preserving procedure and a joint replacement procedure is the extent of the damage. Really, the extent of the damage, if it's really in localized or a small area, like the top picture on the right, then sometimes the arthroscopic procedure works. If, on the other hand, the damage is all throughout the joint and the whole joint is affected, then, a replacement is more the way to go. So I use the analogy of a car tire. So if you, have a flat tire and you take it to get inspected and they find a hole and it's able to be patched, that's like an arthroscopic procedure. If, on the other hand, it's completely blown out and they can't patch it, then you need to replace it. And that's a joint replacement. All right, so when should you consider surgery? So if it's end-stage arthritis, sometimes people refer to that as bone on bone. If it's pain affecting activities of daily living, so, you can't even walk around the house, you can't, stand in the kitchen, you can't get up and go up and down the stairs or go to the bathroom, that's a serious indication for surgery. If you've tried and failed conservative treatment, and also if the pain affects your sleep, if you can't get a good night rest, that has a tremendous impact on quality of life. And then also to consider surgery, of course, you have to be in good health. You have to be medically cleared. So those are sort of the indications to undergo surgery. All right. So moving on to the next section. So talking about joint replacement, this again, it has advanced a lot in even the last 5 years or so. So when I gave this talk about 10 years ago, it was, okay, people were staying 2 days in the hospital, maybe 3 days. Majority of people, sometimes 1 day, but nowadays we can do this as an outpatient procedure. It's done at a surgery center. You go home the same day. Some cases people stay overnight. People are up and walking the same day. You don't have to have a urinary catheter, and the blood thinners that are given to patients after surgery are just baby aspirin. It's a lot less aggressive, so to speak. And this has really been accelerated in the face of, the pandemic. Pandemic shutdowns have really led people to realize that outpatient surgery is safe and effective. And primarily because in the last 2 or 3 years, while we were going through this, hospitals were shut down. So people had no option but to have it as an outpatient. And really that has kind of spurred the development of safer and safer procedures to do it outpatient.
What is a complication? Where does the outpatient surgery center take?
Yeah, so if for example, you're in the recovery area and you have a heart rhythm problem or something unexpected, and that's very rare, but if that is the case, if that were, God forbid, to happen, then we transport you to the hospital, to the emergency room.
So is it the nearest hospital?
Yeah, well, yes.
Because some of the surgical centers are in areas where I was going to go to the nearest hospital.
Okay, not the surgery centers that I work at. And
Oh.
frankly, yeah, we operate out of surgery centers that, have good facilities nearby.
Are near.
Yeah. And so what's the upshot of doing it this way? People are like, is it just insurance trying to save money, et cetera? Is there actually any benefit? And people have actually shown lower risk of blood clot, lower risk of urinary infections and other medical problems. So getting people up and moving earlier is beneficial. It's good. Again, less than 10 years ago, this was a research paper that I did, and we were debating looking at if staying 3 nights was necessary. And now it's like asking, okay, can we do it as outpatient? And it's yes. So why is going home better? Again, early mobilization, walking the same day, that reduces the risk of blood clot. If you lay in bed, you're more prone to developing blood clots, as well as your lung function decreases. Okay, so the lungs collapse if you aren't upright. And so laying in a hospital bed is actually bad for you from that perspective. Constipation and the risk of blood clot. Being in familiar surroundings reduces the risk of delirium, meaning being disoriented. If you are in a hospital in the middle of the night and you wake up, you don't recognize where you are, you might be disoriented, get out of bed and fall and hurt yourself. And that has, unfortunately, it happens because people are after anesthesia and then they wake up, maybe don't realize where they are. So you get better sleep at home with fewer interruptions. People check your vital signs. People, there's beeping, from hospital monitors. If you've spent the night in the hospital, the sleep is not very good. So being at home leads to better sleep. Familiar food, fewer germs overall. If you're in a hospital, again, you could be in a wing, not in a room with other people, but in a wing where the nurses are also taking care of other sick patients, et cetera. So that's, again, one argument for going home. Blood draws and dressing changes are largely unnecessary, and vital sign checks also, because, again, the surgery has developed to such a degree that it's streamlined, it's safe, and we know what to expect. Okay, there we go. Of course, outpatient surgery is not for everyone. So if you have medical comorbidities, meaning heart or lung problems, liver or kidney problems, bleeding, blood clots, any history of a serious issue that makes a hospital setting safer, then the hospital is totally fine. And, in a lot of those cases, people stay overnight. And believe it or not, staying for less than 24 hours, even overnight, is still considered outpatient. So by the insurance definitions and things like that. Also, if you have to have revision or complex surgery, meaning if you've had previous, maybe like a plate and screws or previous hardware in that joint, then, then a hospital setting might be better. If you have a preoperative level of not being able to move very well, like if you're in a wheelchair to begin with, and have limited mobility, then of course, then you go into the hospital so that you get physical therapy there, and then probably rehab facility placement. And then also lack of a safe rehabilitation environment at home. That's another social factor that sometimes pushes people towards having a hospital-based surgery. But the Hip and Knee Society, which is the body that I belong to, that looks at these things, has said that this is very it's safe, effective, and it's basically, it comes down to the surgeon and their institution. If you have performed the surgery many times and have a good quality record of safety, then you can consider doing this. And as long as you keep a record of how well you're doing, so it starts with an emphasis on quality and safety. And so from that standpoint, what has allowed the transition from something that was a long hospital stay before to outpatient surgery is that the contemporary surgery is done through a smaller incision. Improved instruments and smaller implants have allowed that. A shorter operating time. The surgery is now 1 to 1.5 hours. It's really much less than it used to be. And so from that standpoint, you're not under anesthesia too long, and less blood loss. So no one's getting blood transfusions these days. We give medications to prevent blood loss, to prevent bleeding, and then we also use specialized techniques to reduce bleeding. And so by making it more predictable and safer, that has improved the ability to do it in an outpatient facility. And so if you have any questions about that, you're not alone. Talk to others who've gone through the process. We give extensive educational information beforehand, to the point that patients say it's too much. And we call postoperatively also to check in, so of course, if you are having any issues at home, we want to know about that so that we can advise you what to do. And there's a physician and a physician assistant available 24/7 for any questions that might come up. All right. So that's the first part, talking about outpatient surgery. Now we're going to move on to the anesthesia aspect of this that has evolved. So you may have heard that contemporary hip replacement or knee replacement is now done with spinal anesthesia. People oftentimes have questions about that. I don't want the needle in my back. Why do you have to do that? Is that really the best thing for me? So the two ways that people undergo anesthesia for hip or knee replacement surgery is spinal or general anesthesia. Just to briefly explain the difference between the two, spinal anesthesia is when a patient is numbed from the waist down. So you inject numbing medicine, basically like lidocaine, into the area around the spinal cord to numb the patient temporarily. And it usually lasts about 2 hours. And after that, the medication wears off, legs wake up, and then you can walk again. It's akin to what women get for labor, childbirth. And so it's the same kind of thing, but for childbirth, you get an epidural catheter. So they actually put a catheter there and you're delivering that medicine continuously. With a spinal, you just get one-time shot. And so it's even less than that, okay? So, epidurals are very safe, so spinals are even more safe because you're not even getting a catheter. General anesthesia, on the other hand, are when medications are used to put you to sleep, but fully to sleep. You have to be paralyzed, basically. And because your muscles completely shut down, then you need a breathing tube to help you breathe. And so that involves giving a lot more medicine. And from that standpoint, there are pros and cons, right? And so, right off the bat, both these methods are safe and effective, and we use them all the time. And it really depends on what the best option is for you. For most cases, because of the way this is developed, spinal anesthesia works very, very well and reduces any risks related to anesthesia. Yeah, so basically someone who has had back surgery, that has caused a lot of scar tissue, spinal fusion, something of that nature that makes it impossible to do a spinal. Or maybe someone has a bad scoliosis and, it's hard to figure out where to go. And very rare medical conditions, like certain heart conditions where a spinal anesthesia actually lowers your blood pressure, and that's actually helpful for the surgery. So we like the spinal anesthesia because it actually lowers your blood pressure. But if you have a certain heart condition where that could not be safe, then we would avoid that. But that's an excellent question, and that's a discussion between patient and anesthesiologist and surgeon. Oh, yes. Yeah. I'll go. So the question was, when is spinal anesthesia not possible? Yes.
Follow-up question for spinal: is the patient cognizant of what's going on? Can you hear and see?
Right. That's an excellent question. The question is, after a spinal anesthesia, can you hear and see what's going on? Are you like totally awake? And the answer is no. They still give you medication to help you take a nap. All right. So you're given light sedation, very light sedation to take a nap. Excellent question. Okay, so why is spinal anesthesia possibly better? Again, spinal anesthesia is not new; it's been around forever. But the fact that joint replacement surgeries have gotten shorter and more effective and efficient has made it so that it works under a spinal anesthetic. A spinal anesthetic, when you do the shot, it only lasts a couple of hours. So back when the joint replacement surgeries were taking longer to perform, then spinal anesthesia is hard to do for that case. But now that the operation tends to be shorter, you can apply spinal anesthesia in this instance. Why is it possibly better? Because you're avoiding opioids for one, before and during surgery. Opioids, we've all heard, cause problems. Less postoperative nausea with, when you get general anesthesia, oftentimes people have nausea and reactions associated with the medicines. You could possibly avoid that. And then there's also cognitive effects related to general anesthesia. This is still a point of, kind of research. There's been some research showing that general anesthesia on the brain has some lasting effects where it can cause some issues related to cognition. Okay. And so that's something that's very important to my patients. They want to be able to think and process clearly, but with general anesthesia, it could, have this lingering effect of putting you into a slightly, haze or, not being able to process things as well. And that's still a point of research. So it's not been fully kind of understood yet. So if we can avoid that, spinal anesthesia seems to be a good option. I lost the mouse there. Here we go. All right. What about pain control? So there's been a great emphasis on reducing opioid consumption with the opioid epidemic. Okay, so to deal with that, we give a pain medication cocktail before a person even has surgery. So in the preoperative area, we give a combination of Tylenol, anti-inflammatories, and a weak opioid to kind of preemptively counteract pain. Then a variety of long-acting medications are injected around the joint. These are numbing medications as well as anti-inflammatories that then help to reduce the pain locally, okay? There's nerve blocks. They are now performing nerve blocks for the hip and the knee. So basically there are nerves around the hip and knee where the anesthesiologist injects some medication, just like a spinal, that temporarily puts the nerve to sleep. And that can last 8 to 12 hours. And the reason that's really helpful is that by avoiding that shock of the initial pain from surgery, when it actually sets on, when the nerve block wears off, it actually comes on not as strong. And then you're given a postoperative pain regimen consisting of anti-inflammatories, Tylenol, and hopefully a small dosage of opioid. So by having this multifaceted approach, you're not just relying on opioids. It used to be just give a whole bunch of opioids, and that's not a good idea because it gets people addicted. Of course, opioid side effects include mental status change, so people can get drowsy or loopy. You can get constipated, you can get nauseous, you can breathe slower, it can shut down your breathing, and it can cause also itching. So from that standpoint, we try to avoid opioids as much as possible. And you know, this is a research thing that I did before, looked at nerve block and adductor canal, which is for the knee. And this had a tremendous impact, not only on the immediate pain in the day or two after surgery, but even down the road, like 6 weeks and 3 months later, people were doing better in their recovery because they had a nerve block versus not having one. So it's got tremendous impact for recovery. All right, so next, moving on to hip replacement. Yes. Okay.
We're gonna do questions at the end, so if you can just hold on to your question at the end, we'll do a segment.
Yeah, just like write it down so you keep it in mind. But yeah, we'll take all the questions at the end. Thank you. All right, so hip replacement, give a brief animation of what a hip replacement looks like. Okay, so basically go in and, you know, imagine this is an arthritic joint. We remove the ball, put an artificial metal socket and a plastic cushion inside the metal socket, a metal piece inside the femur, your hip bone, and a ball, and that comes together and that replaces the arthritic joint. So this is actually what a joint replacement looks like. And I have a knee model that I'm going to pass around that you guys can look at if interested. So this is a knee replacement. You've seen what a hip replacement looks like, okay? So another relatively newer development in this field is a direct anterior hip surgery. This is something that we commonly get asked, you know, do you do direct anterior hip replacement? What is the direct anterior approach? The direct anterior approach is a minimally invasive hip replacement technique that allows good access to the hip without detaching any muscles or tendons. So traditionally, there are 3 ways to do a hip replacement: from the front, from the side, or from the back. And the direct anterior means through the front. And by doing it through the front, you avoid cutting any muscle or tendon, and that's what the benefit is, okay? Whereas from doing it from the side or from the back, you do have to cut muscle in both those instances, and that leads to a slightly slower recovery. Now, can you have it done through those means and still do very well? Yes. And that's been done for a very long time. But the direct anterior approach is what we consider a better way of doing it now. It's actually been around for a very long time. So the direct anterior approach, although people think of it as being new, is not actually new. It's actually been around since 1881, been used for a variety of indications, but not as much joint replacement until recently. And that's because there's been a surge in proliferation over the last 15 years due to an interest in doing this less invasively, due to us trying to do the surgery better and more efficiently than before. And that's really because newer instruments have been developed to make it feasible and safe. Older generation hip replacements, these implants were very big and long. They go halfway down your leg. And the newer generation implants are much smaller and are able to be inserted through smaller incisions. And the reason for that, and we'll go over that in the next section, is that the materials and the implant design is better now. So the traditional versus anterior approach, the traditional approach, again, it's a longer incision, tends to be an 8 to 12 inch incision. It's approached through the side or the back of the hip, you know, going through the buttock muscle. So you have to go through some muscle, which then delays the healing process. Whereas an anterior hip replacement is a 4-inch incision, it's fairly small, and muscles are not disturbed. Why is this beneficial? So basically, we think about the degrees of range of motion that are necessary for your hip. So for example, going upstairs, you bend your hip 60 degrees or so. Getting up from a chair, your hip is flexed 100 degrees. And then picking something up, you're bending your hip even more. You're bending it about 110 degrees. So why this matters is when you do an anterior approach, you're weakening the structures in the front of the hip. Okay, when you do a posterior approach, you're weakening the structures in the back of the hip. Now, when you weaken those structures in the back of the hip and then you flex your hip up, that's stressing those structures in the back that you just cut through. And that predisposes to the possibility of the hip popping out of socket or dislocation. Okay, so wherever you go in is where you create a point of weakness. If you go in through the front, you make a weakness in the front, whereas you go in through the back, you create weakness in the back. It just so happens that most of our functional daily activities rely on support in the back, sitting, tying your shoes and socks, crossing your legs. That relies on strong support in the back so that the hip doesn't pop out the back. Very few things that you do, in fact, basically nothing that you do really stresses the front of the hip. And so the chance of dislocation through the front is very low. And so that's why doing it through the front may reduce the risk of dislocation or the hip popping out of socket. So talking about the risk of dislocation. So typical precautions, traditional versus anterior. So when you do a traditional hip replacement, you've possibly heard of people being advised to not cross their legs, not bend their hip past a 90-degree angle, not turn their feet inward or outward, and to sleep with a pillow between their legs. And if you have to think about all that and follow these precautions during the recovery process, that does slow you down. And that's why the recovery process for a traditional hip replacement is slower. On the other hand, with an anterior hip replacement, you can do all of those things. You can cross your legs. You can, you don't have to worry about bending 90 degrees. You don't have to sleep with a pillow between your legs. You don't have any restrictions right off the bat. And because you can do all of those things, your recovery goes a lot quicker. And so that's the perceived benefit of doing an anterior versus a posterior hip replacement. So again, the potential benefits of direct anterior mean a decreased hospital stay and possibly quicker rehabilitation, a smaller incision, less muscle disruption that can allow a shorter recovery time, potential for less blood loss, less bleeding, less time in surgery, and potentially a lower risk of dislocation. The potential downsides are that it is a smaller incision, so there is potentially less visualization. I use the analogy of building a ship in a bottle. So it does definitely require more technical expertise, and so from that standpoint, being able to see less with the eye means that you have to use other techniques to account for that and make it safe to do. And so we use X-ray to visualize how the parts are put in, and also robotic surgery, which is something I'll address in a future section. The other thing that can occur is there are nerves that go on the outer aspect of the thigh, skin nerves, which kind of control the sensation there, right in the pocket region. And sometimes people after an anterior hip replacement can get a little bit of numbness in that area. And it's usually something that goes away with time. Sometimes it persists, but it shrinks down to a small area, and it's usually not something that is a big problem in any way. All right, next section, talking about improved biomaterials. So these implants have developed a lot over the last 20 years or so. So first of all, we are using porous metals for implants. Okay, so these are textured titanium, which allows the bone to grow onto the prosthesis and lock it in, and then it becomes a permanent part of you. And so the upside of this is that so the traditional fixation of a lot of implants was cement. Okay, and so that's a grout that breaks down over time. It's kind of like gluing the implants in. And that's what really controlled the longevity of a hip or a knee replacement, is if you use cement or this glue, it breaks down over time. On the other hand, if you use this type of biologic fixation, meaning the metal, the bone actually heals to the metal, then that interface regenerates itself over time. It becomes permanently fixed. These concepts have been in use for a while now in hips, but they've even improved for hips, allowing for for these stems to become shorter and therefore and still achieve reliable healing. Okay, so the improvement in that material has allowed these implants to become smaller, but recently it's also been developed more for knees. It's become more and more reliable in the setting of a knee replacement as well. People often ask about the metal. Is it a problem if I travel through the airport and things like that? No, it's not. The newer metal detectors don't set off. And if you went through an older metal detector that sets off, then they just wand the area. You know, as you can imagine, there are millions of people who travel around with joint replacements, and you know they know how to deal with this. Also, we don't give out the cards. You know, giving out a card, you can imagine, you know, people can just give the card to their friend, or someone can, you know, forge a card. So that's not something that's really done to bypass a metal detector. Okay. In addition to better metal parts, there's also improved plastics. In hip replacement surgery, the rate limiting factor in the past was that the plastic would wear down over time. These newer generation plastics have been made more durable than ever. Within, you know, in laboratory testing, you know, 25 plus years with no appreciable wear. Okay, so it's really, really resistant, strong, and durable. And despite being performed in younger and more active patients, these implants are doing exceptionally well. The other thing with that is, because the plastics are more durable and wear resistant now, it allows us to use a larger ball in the hip joints. Okay, so before, because the plastic wasn't as durable, you have to make the plastic thick so you don't wear through it. But because it's very durable, you can make the plastic thinner now. And as a result, if you make it thinner, you can make a larger ball, which again protects it against dislocation. Okay. All right. This is the last thing, which is robot-assisted surgery. This is something that has developed, become in vogue more recently as well. And what people oftentimes ask is, well, is there, you know, it's not something like, you know, the Terminator, like you know, something like that, doing surgery, Transformer, or what have you. It's a robotic arm which I control during the surgery to help make the operation more precise and more accurate. And here's the thinking: a surgeon's eye is very accurate. You know, we do this a lot, but it's not 100%. You know, it's not like a computer, so to speak. So the idea of using a robotic system is to get it as accurate as possible within a millimeter. And so that really comes into play with a knee, which, you know, you pass around, you see you have ligaments that are still your own. Okay, you replace the inside of the joint, but the ligaments are still your own. By doing the surgery robotically, the idea is to get it as perfectly balanced as possible, so that the ligament on the inside and the outside of part of your knee are equal. Okay, if you put it a millimeter or two off, then the ligaments might not feel equal, and that can cause post-operative pain and swelling and issues like that. And so that's why, by making it as equal and balanced and perfectly positioned as possible, by making it as perfectly positioned as possible, you can enhance the recovery process. And the real one of the upsides too is it really allows us to size the components to the patient's bone. make sure that you're getting an optimal size that matches you. Use the analogy of, going to a shoe store. You don't want one that's even a half size too big or too small. You want one that's just right. Multiple studies have shown reduced outliers in implant position or sizing, less postoperative pain, greater patient satisfaction. All right, so wrapping this up. So joint replacement surgery is a big deal. I understand it's a big deal for everyone, for you, for patients who are considering this, but just know that it's very routine for us. We've done this thousands of times, and while it seems routine for us, we still try to make it as personalized and as compassionate process for you as possible. Definitely encourage everyone to talk to others who've gone through the process, family members, friends, neighbors, everyone that you can, to see what their experience is like. Had patients who joined Facebook support groups for people who've had joint replacement. And particularly too, some of them had, they wanted to kind of share the experience of being an athlete and returning to sports. And so you obviously need to talk to other people who've had that process. And so I know it's a big deal, and it's a weighty decision and things like that. So if you are considering it, definitely talk to everyone you can. We're happy to provide our opinion, and then I also encourage everyone to see what the best option is for them. Okay, thanks for coming out, and I'll be happy to take any questions now. And Zoom questions as well, yeah. Can you just keep track of people who are raising their hand on Zoom? Okay, all right. Yes.
You just mentioned that the robots are not for proper sizing.
Yes.
You do that when you are in a surgical room? Do you have, 20 pieces to use? A half a millimeter each different?
Yeah. Yes. Yeah, we have. Oh, okay, sorry. The question was, do we have all the implant sizes available at the time of surgery to choose from? Yeah, and to make the perfect fit. And the answer is yes. Even though we have a rough idea of what a person's size might be going in, we always bring all the sizes to the operating suite. We do have a preoperative scan, okay, either X-ray or a specialized CT scan that sizes your bone, okay, but of course, scans are not perfect, and so when we look at it during surgery, and if there's any discrepancy, we do have all the sizes available, every single size. Yes.
I had replaced
Yes.
and I had it like 15 months ago.
Okay.
And I had it was perfect. I came home, I made cake, I made dinner.
Great.
Except, I had no pain. Absolutely not even that evening. My water down. I like to go to one and I died.
Oh no.
I had 4 revisions.
Oh my
A
God.
week later.
Oh.
But again, I had no pain. Even I took my opioids.
Yes.
I took my opioids up there.
Okay.
But other than that, I probably took 3 or 4 opioids the whole time.
Perfect. So was that do you have a question associated with that, or was it just a testimonial?
That was just, something about it.
Okay. Yeah. So there was just a patient testimonial, meaning, she had very nice of you to share. Thank you that you had hip surgery 15 months ago and day of surgery, walking, no pain. But then, you fell and fractured a part of your femur, and then you had to have a revision, unfortunately. But yeah, that's unfortunate. So things like that are hard to predict, but I'm glad the initial part of your recovery was so good.
And the first was done the outpatient.
Yes.
That was perfect.
Good.
I was in and out.
Okay.
No problem.
All right. Okay. Okay. Yes.
Yeah, this one is 2 years old at the end of the month, and this one is a 3-month-old baby. I'm still waiting for pain. This one, I was in the hospital for 5 days, I was bled out, blood, and sodium dropped to like 122, couldn't understand why I wasn't in a coma. And I was like, this is what happened. And, I just felt like I had been blown off. And then 3.5 months after that, I had an obturator dislocation.
A what? Oh,
An obturator.
Okay.
dislocation of the sinus. And so that was a nightmare getting it back into my esophagus. So I still have, like, they think it's like psoas tendonitis, it still hasn't resolved. This one was replaced in July, and you know, they say, oh, you know, you're gonna be up and blah, you know, et cetera and so forth. And I'm still waiting to not have pain.
okay.
So, and then they said, well, it's gonna take a year. So they don't say that to you in the beginning. And I'm a former orthopedic, so I've been in the OR with
Okay.
posterior approach. So I've lived this and I've worked on orthopedy, you know, the people who were in the hospital for 2 weeks. So
Mhm.
I'm like their worst nightmare. So there you go. So like, maybe it's like, don't operate on nurses. But, I'm just very frustrated with it just seems like the lack of compassion. Oh, we do this all the time, you know, and you'll be fine, you'll be fine, you'll be fine. And then when you're not fine, you're viewed as, well, you must not be doing what you should do.
I'm sorry, you, I have not met you before.
Yeah.
So, okay, there was a negative patient testimonial about lack of pain relief after surgery. I don't know who did your surgery. I would be happy to see you to evaluate what's going on
Yeah.
as far as if the pain could be coming from not your hip, but say your
Well,
back or other
that's
sources.
a follow-up question. Have you had people that have their hips replaced, have their back issues exacerbated? And that's
No, hip replacement
Yeah.
helps with back issues.
because my back is worse now than it was.
Well, that could be, okay, so the question was, have you had patients who've had hip surgery who've had back issues exacerbated?
Yes.
And again, I have not met you before. I have not performed the surgery, but just to speculate, if for some reason something went amiss, you should talk to your original surgeon, or I'd be happy to see you for an opinion to figure out what's going on. You know, I have not dismissed concerns in that way, shape, or form. I can assure you.
Okay, because they just say, you know, you'll be fine.
So I have not said those words to dismiss anyone. So yeah, I don't know who your surgeon was, but okay.
I wanted to check, because I'm looking at possible knee replacement and so forth. This age thing, is there a certain point that the medical community agrees upon, well, we don't want to do that 90 or whatever, where you have a cutoff because of age?
So the question was, is there a medically agreed upon age cutoff for pursuing joint replacement? And so age is a number, it's more your physiologic age. I've seen 90-year-olds who are healthier than some 50-year-olds. And so now, of course, when when it starts with 9, then you're looking at the possibility of operation is very rare. Okay. But I've operated on people in their upper 80s because they said, I thought I could deal with this forever, but I simply can't deal with it anymore. They thought they could put it off forever. And in that case, operating was the last thing we recommended. But, they were truly, asking for it. And I said, if you can if you're medically cleared and you're physiologically fit, and a lot of our people are, because they take good care of themselves, good nutrition, they've had their medical conditions well managed, then it's feasible at any age. It's really, it's really possible. Again, it's become more streamlined, safer overall. Yeah, so there's no specific age. People have done it at 90, but it's of course more rare.
That's a longevity of the material that you put in there.
What's up?
How long would the knee replacement last?
Yeah, so the question was, how long will the material last for a knee? And so with the newer implants, you can hopefully 15, 20 plus years, but everybody's activity level, it depends on your activity level, what you're doing with your knee, of course, right? Someone who is going out and playing sports, doing 10,000 plus steps every day, puts more demand on their joint than someone who is sedentary. In either case, though, we talked about the knee replacements now can be done without glue, where it forms this permanent bond. And in that case, it can last you forever, even in a young individual. And so that's something we consider, again, tailored to a patient's bone quality, as well as their expectation for activity level.
And you address the replacement of a knee replacement. Well, I have a knee replacement 10 years ago and never satisfied. I think that how would you go about replacing a
Yeah, so you have to figure out what was going on with that. Okay, so you're in the unfortunate situation. Oh, sorry, the question was, can you do a replacement of a knee replacement? The answer is yes, that's called a revision. You're in the unfortunate situation where the replacement may have not been perfectly kind of suited to your joint. And that's the situation we're trying to avoid with the newer technologies and the ways that we do things now. When you do a replacement of a replacement, you have to figure out, why was it causing pain in the first place? Is the kneecap not working properly? Is the sizing of the implants not right? Is it not positioned properly? Is it, is the angle of your leg slightly off? What's causing it? And if you, for being successful at revision, you have to be a good diagnostician and figure out what the problem is. And then you can attack that problem. Does that answer your question? Okay, but it's possible. Yes, it is possible.
Talk about the first 4 to 6 weeks of therapy following.
Yes.
Can you discuss that?
So hip and knee, slightly different. Hip recovery is generally a little bit, can I address the first 4 to 6 weeks of recovery after surgery? So with physical therapy, yes. So that was the question. Hip and knee recovery are slightly different. As everyone will attest to, the knee, even though it's done less invasively now, is slightly tougher of a recovery because, bending your knee, going up and down stairs, etc., involves putting stress on a joint that's been operated on, whereas the hip just moves more smoothly because you don't have to cut any muscle. Either way, though, the first 2 weeks of the recovery are at home. Okay, so a home physical therapist visits your house. They help you use a walker safely, get around the house, and then navigate the stairs to go up and down the stairs, and then work on getting out of the house. So that's the first 2 weeks, home physical therapy. They help you do your daily activities, going to the bathroom, going to like your shower or bathtub, getting in and out of bed, things like that. Then after those first 2 weeks, you come to a post-operative visit with me where we check that everything's going okay. At that point, the bandage comes off and you can shower and do everything. And you can in fact shower right away, but you just have to keep the area covered. But after that, well, you've been to the doctor's office, so you can also get out of the home and you can go out to physical therapy outside the home. And so that's when you start outpatient physical therapy. Now for hips, you may not need much outpatient physical therapy. It's just usually walking and doing some exercises that everybody can do even at home. But for knees, you do have to go to outpatient physical therapy where they work on you more intensively. And so you're usually using a cane by that point, and you could, everyone transitions off a cane at different rates. And then in terms of driving, the left leg, if you had surgery on your left leg, you can drive within a couple of weeks. With the right leg, though, since it's your driving leg, you usually wait 4 to 6 weeks.
we're gonna do some chat questions. We have a few, and then if able, as potential, some of those could be questions you have as well. So I feel like I'm right
Okay.
here, so I'm free to go.
Okay, we're gonna do some Zoom questions. So for knee replacements, you say patients are discharged home. Can they do stairs immediately, or if you must use stairs at home, do you need to stay elsewhere at first? That's a good question. So I encourage people to try to minimize stairs in the beginning. You won't damage anything. You can certainly do stairs. You're not putting your joint at risk, but it might be less comfortable to do so in the beginning. So even if you have to do stairs, you might just want to go up and down once in the day. You don't want to have to go up and down multiple times during the day. All right. What if surgery also involves ligament repair is another question. I'm not sure if this is in relation to the hip or the knee. In the knee, okay. Ligament repair depends on what ligament. That can be done also. Those situations are more rare, but I would have to have a more detailed discussion with the person to see what ligament is involved. We don't have to take care of the ACL or PCL when we do knee surgery because those ligaments just are not part of a knee replacement. But if it's an MCL or like the patellar ligament, that's a different issue. Okay, knee replacement. Rather than spinal block, is a nerve block in the back of the knee used? Well, you can get a nerve block in the back of the knee, but you would still have some adjunct anesthesia like spinal or general. You can't just have the nerve block. You still have something more, a bigger anesthetic, because if you just block the nerve in the back of the knee, say that's not taking care of the front of the knee or your thigh where we put the tourniquet, you still have to cover more than just the knee. Can both knees be replaced at the same time? The answer is yes, but we try to avoid that if possible. Usually we do one at a time. The reason is that when you do surgery on both, it slightly increases your risk of a blood clot or a heart issue. So if you do one surgery at a time, you can imagine it's fairly safe and it's blood loss is fairly low. But if you do both at the same time, it compounds the risk. And so usually that risk is avoided, and why deal with that? And so unless there's a very good reason, someone has very, very bowed legs or very severe knock knee, where you just do the one side and you can't, if you do the one side, you can't rehab effectively, then sometimes you consider doing both at the same time. For how long do cognitive issues exist with general anesthesia? Again, that is not a settled issue. I'm not going to say there's a definitive answer on that. That's just something that is still being researched. The hospital gives ice packs. Yes, we do recommend ice packs after hip or knee surgery. That helps tremendously with pain. After the knee replacement, I need to have a bandage. Do I need to buy that for when I'm at home? Can I take a shower? Yeah, so we apply a bandage, and because at this point, it's fairly routine, we don't encourage people to change the bandage. You just let it be. If for some reason it needs to be changed, you can contact the office. The physical therapist who comes to your house can help you do that. You don't have to worry about that independently. What is the weight of knee and hip replacement total parts? And does the patient notice any additional weight of the replacements? For those of us worried about our body weight, it's not going to tip the scales. It's not, you're not gaining a few pounds because of it's very light. It's a few ounces. How is the joint initially fixated to allow time for osseointegration to occur? Well, this person has some medical lingo. Osseointegration, that's bony bonding of the prosthesis of the metal to the bone. So that's done by wedging the part, either the knee replacement or the hip replacement, into the bone securely. So what you have to do is you have to wedge it in there securely to allow the bone to heal to the metal. Now, again, if you have osteoporosis and the bone is very weak, then you can imagine then you may not be able to wedge a piece in there tightly enough to achieve that bond. And so that's the situation where the glue might be used. Do you go home the same day, send anyone to your home for checking on progress? Yeah, the physical therapist comes to the house to check on your progress. Can you describe the knee replacement process and options? Yeah, we did, yeah. Okay. Maybe they were asking this before we covered all. Oh, yeah. Well, if we want to get, yeah, I know we didn't have a knee replacement video, but the same thing that, that hip replacement video shows, it's very analogous in the knee. I actually hammer things in physically. Okay, so that's okay. I'm 76 and live alone in a one-story house. Can I manage recovery alone? So that it is feasible. It's very feasible, but I do encourage someone who is by themselves to have, some kind of partner in the recovery process. Have a friend, neighbor, be there, check in on you in the first few days. For example, you're not going to be wanting to go outside the home to pick up groceries right after surgery. So someone, can check on you, have that, or go pick up medications for you. And you'll also have someone, to drive you to appointments and things like that. So you can't be totally by yourself. If you're totally by yourself, then being at a rehab facility might be the answer. How long can you take shots before you need surgery? I heard shots deteriorate the muscle. That's not exactly true. So this person's asking if cortisone shots cause deleterious effects. I'm happy to manage people for as long as they need with conservative measures. The issue is not really the total number of shots, but if you get them in a short amount of time. So let's say you take, for example, an analogy is taking, if someone takes an Advil once a day for the rest of their lives, if you're doing that, that could be totally fine. Similarly, if you're taking 1 shot a year or 2 shots a year for the rest of your life, that could be totally fine. The problem is if the shots become less effective and you are taking 4 shots in a year or even more, and they're not being effective, then you have to stop and think about doing something else. So analogously, if you're taking above the recommended amount of Advil in a day, that could cause ulcers, kidney issues, etc. And so that would be recommended against. So it's the amount of cortisone you get in a short amount of time that matters, not the total number. And it does not cause deterioration as long as you space them out appropriately, waiting 4 months or more between shots. How do you handle if both knees need replacement? There was a similar question already. For a Parkinson patient with dyskinesia, is spinal anesthesia still possible? Yes. Yeah, spinal with dyskinesia is not a contraindication. Okay, so how does the need for ligament repair in addition to knee replacement affect the length of surgery and pain management? If you have to have a ligament repair, then it may increase the length of recovery. Again, it depends on what ligament we're talking about. So I'd have to know exactly what is involved here. What happens if infection from dental work? How do you know if affected? So that is a serious, concern. So infection after joint replacement is fortunately very rare. It's less than 1%, but when it happens, can be a serious issue. I took care of someone who had an infection that I didn't do the initial surgery on just this last week. And it's less than 1%. In the initial phase, while the joint is healing, okay, the capsule around the knee and the hip is not fully strong. So it's weak and it's inflamed. And if you get an infection anywhere in your body, say you get a urinary infection or a pneumonia or a dental infection, it could travel into the blood and go to the weak part of the body. So that's why we care a lot about that. So if you develop one of these, infections of other parts of your body, we need to know that right away. You need to be on the appropriate antibiotic to prevent it from going into your blood. That's also why we recommend against dental work in the first few months after surgery, because again, the joint is still healing. If you get dental work, again, it could cause bacteria to go into your blood and affect the joint replacement. If you get dental work in the first 6 months, you're recommended to have antibiotic to prevent that occurrence. Okay, so if you have an infection from dental work, then let's say, okay, you have an infection from dental work, and then all of a sudden your hip or knee starts to hurt. Well, you should let your doctor know right away, because if it's caught early enough, you can do something less drastic. Okay, so basically, if you have a new pain after an infection in some other part of your body, you can basically clean the joint and wash it and give antibiotics to prevent the infection from getting worse and taking care of that way. Now, if someone has had like a long-standing infection, let's say they developed a medical issue, they were in the hospital a long time, and then they developed, an infection of their knee or hip replacement, then that's more serious. And sometimes if that's the case where the infection's been there a while, then sometimes you have to take things out and have an antibiotic spacer or a new joint put in.
So as COVID upticks now again, what is the protocol? What are you all now doing with COVID?
Well,
Things have lessened.
yeah.
Now it bubbles again.
Thank you for coming. So the COVID COVID uptick. So yeah, basically, all the staff are careful to report anything that's going on with them. Obviously, anyone's sick, they don't come to work. Patients, we don't test everyone now. So it's actually, not at this point recommended. Yeah, they used to be really, when it was, even more prevalent, testing everyone, but then you get falsely, positive or people basically canceling surgery when nothing was going on or whatever. But yeah, it's a lot of like basically self-reporting at this point. Now I will say different institutions vary, like a hospital, they may treat it differently than a surgery center. So every institution is different. Okay. How does diabetes and factor into knee surgery and recovery? Yeah. So one of the big things is now managing medical conditions, diabetes, anemia, heart or lung issues. And the big thing that has made outpatient surgery and everything more possible is by knowing how to manage these things. So diabetes has to be well controlled, meaning, A1C has to be well regulated to ensure that surgery is safe. So if diabetes is not well controlled, then unfortunately surgery can't proceed. And similarly for anemia, if someone has baseline anemia, meaning low blood count, that has to be addressed first. Or if someone has, heart or lung problems that are not well addressed, those should be addressed first. By doing all these things, we really preempt a lot of issues that could occur and have made it a lot safer. Excuse me. Okay, well, we've done a lot of these. Anyone have questions out here again?
Just one
I'll go
more
back.
about,
Yes.
My sister had knee surgery last year at the University of Pennsylvania, and they had occupational therapists come and a physical therapist. And it just seems to me the occupational therapist should come before the surgery so your home will be home fitted correctly. Do they do that at one of those instances? Because there are things that she said the occupational therapist told her when they came after the surgery that her husband had to go out and get this, that.
Right.
And so I was wondering how that works.
So yes, so the question was, does occupational therapy come to the house before? That is not a matter of routine, but there's a lot of patient information given to provide education on this matter. So basically, some of the things that may be done to outfit the home to make it a smoother recovery. Again, trying to stay on one level if possible. Raised toilet seat. That's something that's not required, but it can help because low toilet seats, again, you're bending your joints a lot and can cause pain and things like that. People may use grabbers to pick things up off the ground. And that's something that, not everyone thinks of, but, just bending down might be a little difficult in the beginning. You're allowed to do it, but it might be best to have something like a grabber. Avoiding things like rugs, which you can trip on. You're a walker, going over a rug can cause someone to fall and things like that. So there's educational info given on this stuff, but unfortunately, insurance doesn't pay for someone to come beforehand, and that's a different. But a physical therapist comes afterwards. Again, yeah, it's not ideal. I agree. In the perfect world, people would come before, but I guess I don't make the rules for insurance. They want to see that the surgery has actually occurred. If someone never has a surgery, how would they know to send someone? So, yeah. All right, another question here.
Does changing, if you lose weight or gain weight, does that change anything with your knee, the mechanical piece that you put in here? Did it change, make any changes to it? If you lose or gain weight?
No. Well, the question was, does weight gain or loss affect the components that are put into a knee or hip? And that it does not affect the components in any way, shape, or form. The pieces that you put, the pieces that are put in are sized to the bone, and your bones are not changing size. And so that won't affect anything. However, I mean, if someone gains a lot of weight, that could put more stress on your body parts. And so even though you had a surgery that went well and the parts have healed well, once if you gain weight, you could develop new pain, so to speak, because the muscles and tendons are now working harder. And so that's something to be aware of. But it doesn't affect the actual components themselves.
One other question, can you interview different doctors at Ortho Defense? I mean, how would you do that without offense? I mean, I don't want a doctor to be offended because I didn't pick him, but I also want to interview more than one doctor to know who I'm comfortable with.
Yeah, the question was, are people able to obtain multiple opinions at one practice or other practice? And that's absolutely fair. I encourage people to get multiple opinions, okay? And the fact of the matter is you have to be comfortable with whoever's doing your surgery. This is your decision. It's not someone telling you what to do. And so I know it's a big deal for everyone. So you can absolutely get multiple opinions. You just have to set appointments with XYZ doctor, okay? And I don't have control over other doctors' schedules, but I always encourage people to get multiple opinions. All right, some more Zoom questions. Okay. With the new innovations for knee replacements, is weight a factor in denying the procedure? Weight is generally not a factor in denying someone surgery. It is possible to do at whichever weight. I will say there have been studies showing if you have a really, really high BMI, you are at a higher risk of complication or having persistent pain afterwards. Basically, the joint replacement only takes care of the arthritis. But let's say you do a joint replacement, well, with a higher weight, you could still have pain from the muscles and the ligaments being overstressed, overtaxed. Nowadays, there's also newer developments as far as weight loss drugs and surgeries and things like that. So that's not commonly a thing, an obstacle that is insurmountable. We can deal with a weight issue if it's really that much an issue. I've really seldomly encountered that being like an insurmountable thing. Is sleep apnea a contraindication for TKR done with spinal block, meaning knee replacement done with spinal block? So sleep apnea is not a contraindication for surgery with spinal block. The anesthesiologist just has to monitor your breathing status, and they have ways to address that with oxygen, without a breathing tube. Sleep apnea can be an issue with opioids, so it's even more of a reason to avoid opioids, because opioids can slow down breathing and interact with the sleep apnea issue. What advancements in joint replacement surgery do you anticipate in the next 5 years? So it's already done in a very, very streamlined fashion, and the incisions are, it's hard to imagine how much smaller you can even make these incisions, but so that's an interesting question to think about, because as I said, giving the talk 10 years ago, even to now, a lot of things have developed. So I imagine implants will become even better. Okay, so we can make the plastics last even longer. Robotic surgery, I think, definitely will be the wave of the future. I'm not someone who jumps on a bandwagon too early or last. I tend to think of myself as adopting something sort of in the middle. And so with robotic surgery, I do think that will be something that is going to develop more and more in the future. Need for fasting before operation. Yeah, you are advised to fast for the 6 hours before, and that's to avoid any potential for basically what's called aspiration, the stomach contents moving up while you're sleeping and basically throwing up into your airway. So that would be something to avoid. But people are allowed clear liquids, okay, and people are given the possibility of drinking electrolyte balanced solutions to help the postoperative nausea and whatnot. What if rheumatoid arthritis? Will that affect whether you should have a knee replacement? Will it affect the recovery period? So traditionally speaking, rheumatoid arthritis patients got joint replacements at younger ages because rheumatoid is a lifelong condition from birth, versus osteoarthritis, which is wear and tear arthritis. Osteoarthritis, comes from a injury that happened at some point, and then that joint progressively deteriorated over time. Whereas rheumatoid arthritis is a genetic inflammatory condition that affected that joint. And so traditionally, people had joint replacement surgery with rheumatoid arthritis in their 30s, 40s, 50s, at younger ages than people with osteoarthritis who had it in their 60s, 70s. It's still feasible to do these joint replacements with newer rheumatoid drugs, which have controlled the medications which have controlled the condition better. Thankfully, it has delayed the need for surgery in those patients to also ages that match those osteoarthritis patients. But it doesn't really affect recovery or how we do the surgery. How long will it take before I will be able to get back in the gym for light cardio and exercise after knee replacement? So actually, going back to bike riding is encouraged. Stationary bike in particular helps with knee range of motion. So as soon as you can get to 90 degrees of flexion, it's encouraged for someone to get on a stationary bike. Usually that occurs within 2 to 4 weeks. What is the typical length of time between first and second knee replacement? So if you staged bilateral knee replacement surgery, that would basically mean, how long do you wait in between? It's frankly up to the patient. You can wait 2 months, you can wait a year. Basically, you want to wait for the one knee to feel strong and supportive. And if you do have slight anemia from the first surgery, you want to wait for that anemia to resolve and for you to be back to a full tank of gas. Can an anterior approach be used after a partial hip replacement? Yes, I have done that, and that's definitely feasible. What advancements in joint replacement surgery do you anticipate in the next 5 years? I think I addressed this question too. Okay. Okay, that's it for the Zoom questions. Any further audience questions? Okay.
Is there any kind of physical exercise that benefits or harms your situation of a knee replacement?
With a knee replacement, what the question is, with a knee replacement, what forms of exercise can benefit or harm the knee replacement? So generally speaking, impact such as running and jumping is to be avoided because that could put more stress on the prosthesis. Okay, people can play pickleball, can play doubles tennis. Usually people aren't playing singles tennis. That's a lot of running. However, other exercise, golf, done this plenty on people playing tennis, pickleball, golf, just various activities. Generally speaking, lower impact activities are recommended, again, for the fact of, wear and stress on the prosthesis. Okay, I think that's it for all the questions. Well, thank you everyone very much for your time, for coming. I appreciate it very much.